Hello, everybody. My name is Mariel. Today, I'm going to be discussing my DMP project. The title is Implementing a Medication Adherence Assessment Tool Among Adult Mental Health Patients. And these are my committee members. I want to say a very big thank you to Dr. Lida Studley for always being there every step of the way, for the support, the direction, the guidance. I really appreciate everything. I also want to say a very big thank you to my second reader, Dr. Wunderlich Rita. Thank you so much for always being there. I also want to say thank you to my committee person, Dr. Chima. Thank you very much. Now to the main presentation. If you look at the picture on here, we see a picture of people coming from the community, going to the hospital, getting discharged, and having to come back. Mental health generally is a global concern, and it poses a public health challenge. And we have seen, based on the studies conducted, we have seen that medication non-adherence is one of the critical challenge, one of the critical problems that is causing this, among other things. And if you look at it, many of these patients come to us in the hospital. We take good care of them, give them medication, come up with a treatment plan. But when they get discharged, they go back to the community, stop taking their medication, and having to go through relapse and coming back to the hospital within a short period of time. And this is a real big problem. We have seen a lot of this challenge among schizophrenia patients. About 20 to 89% of schizophrenia patients engage in the non-adherent behavior, and this is very concerning. And it's just not schizophrenia alone; it cuts across many of the mental health disorders. So, medication non-adherence is a critical challenge that we are looking to address. That this project actually focuses on. Now, to the aim of the project. This project is the aim of the project is actually to implement an evidence-based tool, which we actually found. We found one evidence-based tool called Medication and Adherence Workup Medication Adherence Workup tool, which is called MDRAW for short. And this tool, the purpose was just to help us evaluate, detect the factors, if there are factors affecting medication non-adherence, if there are factors leading to this non-adherent behavior among our patients, if there are things that are causing them to not, take their medication in the community. This tool was helped us to understand the problem better, and that was actually the aim of this project. The ultimate goal is that when we are able to understand this problem of medication non-adherence, we'll be able to improve the treatment efficiency. We'll be able to improve patient outcome, care delivery. We'll be able to impact the problem of multiple readmissions and reduce waste in the hospital within the healthcare organization generally. And that's one of the significance, and that's what we're looking at. If we look closer at this significance, the main thing we looked into was to actually use this tool to explore the problem, to further explore the problem of medication non-adherence, to create the necessary awareness that we need to create among the care team, among the psychiatrists, the nurse practitioners, among the people taking care of this, the patients in general. We wanted to see if the care team can actually prioritize this problem and help prioritize the treatment, identify the problem, the factors causing these, contributing to the non-adherent behavior, and be able to prioritize treatment, a well-targeted treatment. And that was the significance of this project. We conducted literature review. We looked at several literature, and what we found out was about 27 millions of patients get admitted, mental health patients get admitted yearly. And a large percentage of these people engage in the non-adherent behavior. They get admitted to the hospital, and they have to they get discharged, having to come back, and that is something that is very, very concerning. And it's not just concerning for the patient alone; it affects the hospital, because guess what? It makes the chance of getting reimbursed very slim, especially when the patient comes in and they have to return within 30 days, 60 days, or 90 days, especially within 30 days of initial admission. It becomes challenging for the hospital, and it raises the cost of healthcare. And that those are the things that we saw in literature. And based on all the articles reviewed, we saw that there were central themes. One of the themes that we came up with based on the articles review is FAMNA. We called it FAMNA because it's factors affecting medication on adherence. So the acronym for that is FAMNA. We saw that many literatures looked at some of this problem, and they saw that things like medication-based problem, medication side effect, the knowledge deficit, all of these things are factors affecting the patient. The patient does not understand the medication they are taking, or they just have some side effects that are bothering them so much that they don't want to take it. Other literature stated things like stigma because family members, friends, the support system, they are making certain conclusions, certain statements. They stigmatize mental health, and that also really affected how many of these patients responded to their treatment. They refused to continue with their treatment plan, and they relapse and they have to come to the hospital. So it's a central theme. The other thing we saw was that there were evidence-based practice based on the literature conducted. There are evidence-based interventions that could be used to actually help the problem. One of the things we came up with was relevant assessment to RAT, under which the MDRAW tool fall. So with these two, we're able to, the MDRAW tool is like a 13 to 15 13 item question, but 15 if you look at it, because we have sub question, and it has a 4-point Likert scale, and this was a relevant assessment tool that we're able to use for this project. We actually implemented this based on the evidence presented, and it helped us to actually understand the problem further. We conducted a SAT. We came about over 2,000 research article and peer review article. We narrowed it down to 14. We used specific keywords stated on here. We use different database to help us identify the literatures that could actually help us work on this project. We came up with 14, and we used 13 of those 14 articles were included in the project. We had strengths in the literature. We had weaknesses. One of the strengths included the fact that many of the articles were primary research articles. Many of the articles were reviewed articles. Many of them were between the years of publication. The date of publication was between 5 to 7 years, which is actually good. But the weaknesses that we found was that some of the reviewed articles that we saw a couple of them were older than 7 years, and the other thing was we saw some of the articles had samples that were very small, which made it difficult for generalization. Moving forward, we had gap in literature. One of the main gap we saw that many of the articles looked at the problem of medication on adherence, and they looked at the problem of multiple readmissions separately. But these two factors, these two problems are connected. And so this study was able to bring these two factors and study them together in this scholastic study. The limitation of the study, we had one or two limitations. We had some articles which use interventional groups, but there were no control groups that they could use to, compare the result. Now, to the theoretical framework. The framework that we use for this project is called the theory of planned behavior, and I'm just going to summarize what that theory. The theory presents the idea that the intentions and the attitudes of people are influenced by their beliefs and their conventions and the norms of the society, which is true. So people's belief, people's perspective, people's thinking affect how they behave, how they act, and this was one of the impact on these on our patient, and this perspective is what helped us to formulate this project. That many of our patients, they take their cues from their society, from the conventions, from the norms, and their perspective about their treatment actually affected the way they approach the treatment and made them go into the engage in the non-adherent behavior. And so that is what this theory and framework was about, and that's how it actually impacted this project. Moving on to the next thing, we want to talk about the methods and the design. In terms of the method and the design, these projects actually utilize a quantitative method. The design was both a retrospective chart review and a non-retrospective approach. For the non-retrospective approach, the nurses were the ones that took the MDRAW tool and distributed it to the patient upon arrival on the unit, and that was very effective. That was a very effective approach that we used and utilized in this study. And with the retrospective approach, we were able to go into the chart, the electronic medical record, to look into it and see if the care plans were documented, if the interventions given to the patient were documented, the factors of non-adherence that were identified, if they were communicated in care rounds and discussed, and then the documented in the care plan. And that's the design. That was the design we used. We had two instruments, one of which was the MDRAW tool. The MDRAW tool was the main tool of implementation. Like I said earlier, it had 13 item questions, 13 to 15, of course, and we had four Likert scale 1 through 4. Never, rarely, sometimes, and often. And the use of this Likert scale actually made this tool to be very, very valid and reliable. This second data collection tool was the tool that we used. As the PR, I kept going to the unit. I visited twice a week. At the end of the week, I go in to collate all the forms completed by the patient, and many of the forms, the responses were documented on this tool as in nominal values, and that was how this was done. And I had to make several calls every day during every shift, twice a day, just to make sure I'm keeping track of the admissions, the discharges, and we're able to make all this recording on the second data tool. Now let's move on to why the tool. Why did we pick this method? Why did we use the design? We actually used the design of the non-retrospective and the retrospective approach. Now, the non-retrospective, the nurses were able to take the tool, pass it on to the patient as soon upon admission, as soon as they get in, and the patient completes the tool and returns it back. They complete it anonymously, and they pass it on to the nurses, and we are able to collate the data. This approach was very, very effective because it prevented the need for using any extensive need for consent, and it also helped the project in general. With the retrospective chart review, we're able to go in whether the patient was after the patient has been discharged, or whether they are even there once they've completed and everything has been done. Go in every weekend and see what has been done, whether the care plans were completed. So this method actually helps us to know whether the care plans were done, whether the forms were completed, how many of them were completed. So it was an effective approach for this project. Now, how did it contribute to the answering the question of inquiry? Remember, the question of inquiry is that we were trying to see if if we implement the MDRAW tool, if it was going to help the staff to include the factors of medication and adherence in the patient care rounds and the care meetings, and it really helped us answer this question because we're able to know how many of the participants, how many of the patients were admitted, and that many of them participated in completed the form, how many of the questions care plans were done, the concerns that were raised, if they were addressed in care rounds, and if they were documented in all. So these actually helped us to respond or answer the questions we're looking to answer. In terms of sample, we didn't actually anticipate any specific sample for this project. The project was dependent on whether or not there were admissions within the 8-week period. Again, the project lasted for 8 weeks. The first week was the period of orientation for the nurses, but within this period, we had we included patients who were between the ages of 18 and 19. If they're less than 19, they weren't included. If they're older than 69, they were not included. But a total of 44 patients came on to the unit, were admitted at that time, and 30 of those patients participated in the study, and that was really great. So there was no specific chosen specific amount of numbers selected at the sample size. It was just dependent on the amount of patients that were admitted within the period. Now, talking about the data analysis, we use descriptive data, we use quantitative data. With the descriptive data, we were able to see that 40 patients participated, even though 44 were admitted. Care plan documented was 30, the MDRA2 completed but were not documented was 10, and then we had forms that they were neither completed nor documented, meaning that there were concerns that were raised, but they were neither raised nor addressed. We also use quantitative method, and we're looking at the quantitative method. So the statistical test that we utilized for this study was frequency and percentages. They helped us to look at the issue of medication, the factors of medication non-adherence among this target population. We identified the fact that there were medications-based factors, there were knowledge-based factors, income-based factors, stigmas-based factors, and we use frequency to identify how since the questions were categorized, the MDRA was subcategorized into these four factors based that I just mentioned. We were able to use frequency to analyze how applicable the questions were to the patient. And we found that the questions that fell under stigma based factors were actually more applicable to the patient. There was we used percentages as well. With the percentages, we were able to know the proportions of the forms completed, proportions of the care plans documented, and or things like that. The variability in this study, there was no variability because we had no median, we had no mode, we had no mean, we had no median. The project lasted for between 8 weeks, and here's the result we came up with. 44 patients actually completed the form. 90% of the patients participated in the study, and that was really, really great. We saw total number of forms completed, total number of forms that were not completed, total number of forms that were complete of care plans documented, and we see here the forms that were completed, care plans that were not documented. So here's the key: total number of forms completed, total number of forms not completed, that everything I just pointed out. Now, this is also a table that tells us about that actually shows the outcome of the result of the project of the study. We had 44, 90% participated, 9% were just the number of forms that were not completed. Well, you see that we had 25%, which depending on who is reviewing or who is looking at this, it's may or may not be significant. So 75 care plan documentation, that was really great for us for the study. We had limitations in the study. There were certain limitations. The study had, the study was designed, but the problem is we didn't have pre and post assessment. We couldn't even have like a follow-up assessment or follow-up questionnaire that could actually identify if those factors were properly addressed and if it impacted patient in any way, if it impacted or positively added if it had a positive impact on readmission. So there was no post-implementation assessment, and that was one of the limitations that we saw. Now let's discuss about many other things like the process measure and the outcome. We had the MDRA implementation was very, very successful, and we were able to see that the central themes of stigma, the knowledge base, all the factors that we identified, and we saw that stigma was actually more applicable to the patient, and since there was no any other official tool on that unit, this tool became a good tool that they were using to assess patients as soon as they came on the floor. It was very significant, and the result that came out of this was was really very significant. We had 90% of participation, 75% of care plans were completed, and there were a few of them that were not completed. We had contextual element that interacted with interventions. We had some barriers. One of the barriers included the fact that I had gone to request for the approval letter. I've received the approval letter, but then there was a change in leadership in the facility utilized for this project, and so that affected the project because the new leader wanted me to get a new approval letter. She actually wanted me to start the whole process afresh. That caused some delay, a delay in the project. Also, we had problem with IRB. I had to go into many places for the IRB. Even when I needed support for the IRB, I had to apply for one IRB, and then later, because of a minor tweak in the project, I had to do another IRB. We also had challenges with IRB within the school, but we're able to surmount all these contextual elements that interacted the barriers. But we use frequencies and percentages to determine the significance of the outcome. And based on what we've analyzed so far, we could see that there was significant participation. Though we had about we had about like 9% HEMDRAW questionnaires that were not completed, and we had about 31 that we could say forms were neither completed nor documented. But the project still showed significant, revealed to be was very successful. We had unintended outcomes like the problem of having to apply for IRB. When I needed support, I couldn't find someone. Some of them did not even know where I should go for the IRB. It was a very frustrating process. There was communication breakdown when I had to do like test orientation for the nurses. There were cancellation without prior notice. It was very frustrating. How we had challenges with IRB submission. We had so many things we had to tweak in the process so that we can get approval for the IRB. We had missing data. So when we had this project, there were patients who came on the unit. They were not able to respond to this, participate in the study directly because they were not at that point when they could actually participate. They were not feeling so good. So those patients, we categorize their responses or their anticipated responses as missing data. Now, the forms that were not completed, not documented, we had care plan documentation. We also categorized those one as the missing data for the study. The implication for practices, one main implication is that this study was actually able to highlight the problem to the care team, creating some form of awareness, and it was able to improve the approach to care, was able to improve clinical outcome and care delivery, especially for this target population. For the patient, it helped with care delivery, it helped with outcome. For the healthcare community, we are hoping that this is going to help reduce the issue of readmission. It will reduce the cost for healthcare for mental health patients in this regard. In conclusion, the project was very, very successful. The MDRAW tool was effective in gathering all the information we needed for regarding factors affecting medication and adherence, and we were able to create awareness among the care team, and that was really, really great. And we saw that maybe this kind of awareness is actually what we need to make a change in this among the target population. So it had a very positive impact. A positive impact was made because we're able to create that awareness, and we're able to highlight the problem, helping the clinicians to see the problem in the eyes of the patient. Now, what could we have done differently? One thing I know that we could have done differently in this project was to actually design a tool, post-assessment, post-implementation tool that could help us to actually see if what we did was very effective. That's something we could have done differently. For future practice, I do hope that we could come to the point where we will be able to, design have a study that will be designed in such a way that we will have support-based system for the patient. And if that is put in place, that will really go a long way for the patient and will help them. And we can have a situation where we are able to educate people to help them see and know that mental health is not supposed to be something that should be stigmatized. In conclusion, the DMP project has the DMP in general program. The DMP program has been eye opening, it has been life changing. We've had tough processes and tough situations, but we know that things like that are designed for better achievement and better outcomes. Thank you very much. And these are my references. Thank you, thank you, thank you.